Hi, everybody. My name is Garrett Schmidt. I'm the managing editor for ACO Exhibit Hall, and I would like to welcome you all to today's moderated discussion hosted by InfoMC called How Medicare Advantage Plans and ACOs Can Better Manage Risk in a Value-Based World. This is a really important topic, something of a lot of interest right now, so glad you joined us. A few items of note before we get started here. Just some housekeeping stuff. All attendees have joined the webinar today in a listen-only mode, so you don't need to worry about muting your microphone. That's already been done for you. And I'd also like to let you know that the webinar is being recorded, so you will have the opportunity to rewatch the session and or hopefully share it with colleagues and friends. And a link to the recording and also where you can download the slides will be sent to you. I'll email you personally following the presentation. Finally, during the webinar, we want to hear from you, so please submit your questions to our presenters at any time using your attendee control panel. And if you'd like to address any specific one of our speakers, you can do so there. And we will answer as many of those as we possibly can during the Q&A session at the end. But for the questions we are not able to get to, please know that we will make sure to respond to you via email afterwards. But we'll do as many of those as we can in the allotted time. Okay, so without further ado, our presenters today are Dr. Francisco Hernandez, Chief Medical Officer for Doctors Healthcare Plans, Ms. Susan Griffin, VP Administration for Doctors Healthcare Plans, and also Dr. Harm Sherpir. He's the Chief Medical Informatics Officer for InfoMC. So you can see their bios here on the screen. So I think Dr. Sherpir is going to kick us off. So welcome, Doctor.
I guess he's muted.
Thank you, Garrett. Thank you, Dr. Hernandez. Yes, clicking all these buttons. Thank you. Thank you so much, Garrett, for the introduction. Now, let's start by introducing our company. Influency is a healthcare technology company delivering a collaborative care platform to provider organizations and health plans, governments. Our whole person approach enables clients to address the behavioral, physical, social drivers that impact a person's health. We currently have over 26 million lives on our Incado platform. Platform is easily configurable and collects and manages data with interoperability and data exchange from client systems. We are distinguished by strong emphasis on privacy and security. We have numerous certifications, including HITRUST, NIST, MARS-E, SOC 1, and SOC 2. For today, we are delighted to be partnering with our client, Doctors Health Plans, in this conversation. They are a new plan in the Miami-Dade area with a very experienced team of executives running the organization. Their tagline, "Your health, our commitment," I think is the perfect tagline that encaptures accountable care, right? We are accountable for the care that we deliver to you. We are uniquely situated to provide comprehensive and coordinated care by integrating operations and medical management. That will be the main topic for today. And to briefly preview the topics we will be discussing today as a team. Number one, what guiding principles shape your medical management strategy. From there, we'll talk about clinical and operations working together in utilization management and case management. I would like us to touch on our health IT strategy for analytics and interoperabilities. I'm hoping we'll talk about the main concerns toward the stakeholders, patients, providers, health plans, and other stakeholders. And I would like to end today with a look at the most innovative or unexpected decisions that Medicare Advantage plans may encounter in their success. So this will be the brief outline of our webinar today. Excited to be joining you. And let's start with the first question. So Dr. Hernandez and Ms. Griffin, when you started Doctors Healthcare Plan, what were the guiding principles that you had in mind when you built your medical management strategy? Dr. Hernandez.
I don't know if you want to take the first part and then I'll abound on my side, or if you want to do it the other way, but go ahead. And by the way, you're muted.
So Dr. Hernandez, are you providing me the opportunity? This is Susan.
Yes.
Okay. Oh, sorry about that. So, Dr. Sherpier, thank you so much for having us. Doctors Healthcare Plans has truly enjoyed its experience with InfoMC. The product in Cato is what we're using. And so when we started our organization, the guiding principles that we were looking at for medical management strategy really began with the mission statement and the direction from our board of directors and our CEO. And it is understood, you know, as you said, we've been in this for a long time. Any successful organization is looking for strategic leadership. And you'll hear our CEO and all of our key stakeholders within this organization talk about if you take care of the patient, the member, everything else falls into place. So when we first met InfoMC, and I know that you had the slide on there with the social determinants of health, we were looking for that full integration. So it's one thing to have an HMO, an ACO, and just look at clinical health. It's another to have the ability within a system to handle all of those, I call them soft touch points, or if someone's familiar with the patient-centered medical home, those social determinants of health, all of those key elements that are required to have a medical management program and the program description and the system behind it supporting it that will allow for success. So when we're looking at value-based and managing risk, you can only manage your risk if you know where it is, and that's all in structured data. But certainly I would say that was our guiding principle. Take care of the member, take care of the patient. From an operational standpoint as well, everything else will fall into place. And I've had the pleasure of working with Dr. Hernandez now for a few years as we're launching this. And he has always been clinically focused. I'm right next to him or right behind him, operationally focused. And I follow up and try to make his and his team's lives easier with the operational aspect. So Dr. Hernandez.
Okay, thank you, Susan. And I actually was muting myself as well. When I looked into the task that we were going to be facing, my concerns were that we had a system that was user-friendly so that our personnel could use it with relative ease, that was able to perform the functions that we needed, and to do so, allowing us to have a decent workflow so that the time frames, and as you know, many of the things that we have to make decisions on have a time frame attached to them, could be kept and followed appropriately. So that being said, we found ourselves with the mammoth task of looking at several different systems and determining what was more likely to work than not. When we looked into InfoMC, which actually we looked at it more than once because we looked and then we came back to it, we realized that it did have what it needed. And furthermore, we also realized that we had a team of people who were very eager to help and to cooperate. And when you're starting a plan like this, there are so many other competing issues that you don't want to have an additional one by having a software or a vendor that you barely can communicate with, because when you have a problem, you need a solution and you need it quickly. And I think that that is one of the things that got us into the direction of InfoMC more than any other issues with it.
Good. I could see that theme here. You talked a little bit about selecting InfoMC. Ms. Griffin, you also, I think the theme for the day is, and I think you captured it really well, is collaboration between clinical and operations. So let's talk about that a little bit more. How do you work together as an organization to match both your utilization management and your case management programs? How do you coordinate those two in sync with each other? Who wants to go first? Dr. Hernandez, you want to go first?
Yeah, I'll go first. Okay, so the first thing to realize is this is two different systems. The case management is our handling of chronic patients and or patients who have had issues. And it comes with a lot of reporting needs that must be complied with because they're regulated by law. And also you need to be able to capture the information and work with it, because that's how you are going to be more effective in following those who need deeper and further intervention. we found in Encato a relatively strong platform for case management already. And we then had to evaluate and develop the utilization management side. Any company of our kind, healthcare plan, needs to be able to not just authorize things, but make sure that those things are authorized timely, that the information is kept appropriately, and that we capture when all of the different steps in that decision occurred. So the clinical side is seeing the information we receive and making the decision in terms of appropriateness of care and or appropriateness based on the guidelines that we get from the federal government to be able to provide those services. Having said that, there is a burden on us also to be able to show what we have done and how we did it. There's a burden for timeframes of arrival, timeframes for decision, and timeframes for communication of those decisions to the different stakeholders. And that creates an environment where we have several different customers. We have sort of ourselves as a customer, but we also have as customer CMS, the federal government itself, and we also have the membership and the providers. And we have to somehow marry that clinical and administrative side in a manner that satisfies all of those other external and internal customers that will have to deal with this data and that information. Susan, I don't know if you want to add on anything to it.
No, well said, Doctor. So when we are, not only for startup, but for day-to-day operations, when we think about the clinical team, they are member and patient facing. When we think about the operations team, we are CMS facing, we are the state facing. So any of that data that is being produced out of the system where Dr. Hernandez's team is inputting must be structured data, be able to pull it out and submit it to the feds, the state, et cetera. And so one example I want to give for this discussion is that when we were developing our case management and disease management programs, we have 5 levels of severity. And so unique to this organization, and I'll say this for those that are listening in other states, is that if you have worked in the United States, you may not have worked in Miami-Dade. And I will tell you, Miami-Dade County does have a unique population in that, and I know I'm speaking to folks on the West Coast that have other either minority populations. When you look at risk stratification across age, gender, financial stability, et cetera. So when we're in Miami-Dade, for the case management program, those 5 levels of risk stratification are unique to this area. And InfoMC allowed us to take our 5 levels and embed them into the system, such that Dr. Hernandez was our clinical driving source to say, if patient has XYZ or comorbidity, or then this patient will fall into this risk stratification level. Behind the scenes, my team was working on thousands and thousands of lines of data such that we could create a unique case management program. Yes, it is based on evidence-based guidelines. Yes, our Quality Improvement Committee has approved this, and in particular CMS in the state. However, please keep in mind that the nimbleness, it's very, for a system to be able to take what Dr. Hernandez and his team would like to deliver to our members and be able to place it into a system so that it is seamless for his staff. It's many hours of dedicated and detailed work, but InfoMC allowed us to have that unique structuring.
I think that's super interesting, and I think the level that how you described both risk stratification and defining subpopulations where you provide case management and care management. Is there an example of a particular disease condition, say diabetes or hypertension or something, where you could say that's why we're targeting that specific population, Dr. Hernandez?
Okay, we as we look into this, we have numbers that are different than other areas.
Right.
Most, for example, of of the insurance companies that have minorities of Hispanic origin have them as a higher risk of diabetes. And I say this because I am myself an endocrinologist, and we have a significant number of Cuban descent Hispanics, and those are supposed to be the lowest risk of diabetes amongst Hispanics, almost comparable to Caucasians. However, because I practice my specialty, I see a lot of diabetics, and they happen to be, because of the city I'm in, mostly Cubans. And so it makes me wonder if those numbers are right, but that's the statistic that we have. But we also have a potpourri of population from other ascendancies, and we have a significant population with diabetes. It is important to address them differently because our linguistic variations on the language are not the same as some other groups, and our dietary habits do not match other Hispanics, and we have to address those differences when we speak to our population. So we chose diabetes as one of our chronic programs because we thought we needed to give them a unique touch, and we also needed to provide a lot of assistance in Spanish because we have a very significant amount of population that are monolingual in Spanish only. Having said that, diabetes in general for the United States is a driver of cost and complications for members and patients, and therefore it makes sense to try to also address them from that point of view. We structured the program inside of the system, and we were able to do that, as well as for congestive heart failure, among others, based on structures that were not present necessarily when we purchased the system, but that we were able to add on and modify in cooperation and conjunction with the team at Encato. Susan, I don't know if in your end you want.
Yeah.
Before you go, Ms. Griffin, I want to flip us to the next slide because I think that will be a good opportunity for you to further illustrate and build on that. So to make that work, right, to focus your risk stratification and your disease targeting for specific programs for specific subpopulations, that requires an IT strategy. And I'm wondering if you could both comment on your IT strategy, both in the direction of analytics, but also interoperability. How do you tie things together that need to be working together for your program? Ms. Griffin?
And so it is a perfect segue over to the IT strategy, because the example I'd like to provide with diabetes is for InfoMC in our organization, we are also using it in our member services platform. And because of that, when we're thinking about interoperability, when the member is on the phone, or your patient is on the phone, they do not, they are afforded the opportunity to have a seamless decision-making process, a seamless information gathering process. And so, for example, in the diabetic population that we do have a chronic special needs plan for diabetes. Further, in our straight MA plan, we have, as Dr. Hernandez said, we have a large portion of our membership right now diabetic. And if, let's just say in the medical management side, a continuous blood glucose monitoring system was approved, well, that probably has already come through our member services department. So that seamless information, whether we have a provider on the phone in medical management or we have a patient on the phone in member services, they can see that same information. And then further, when we're looking at, again, speaking about diabetics, if we need to have, say, the hemoglobin A1C, that all of our data is getting pushed into, as everybody on the phone knows, if you're doing HEDIS right now, HEDIS season obviously is year round at this point in our careers, but we need to have a hemoglobin A1C. How can an organization have that member or provider on the phone and in real time be able to indicate, did you know, provider, that your patient is due for a hemoglobin A1C? On member services, we have an over-the-counter benefit. Oh, I see here, that you're diabetic. Would you like to use your OTC benefit for a glucometer? Things such as that. So when we're looking at IT strategy behind the scenes, we always took the approach of how is the member and or the provider, so those are our clients, we're client facing, how are they going to enjoy the back end work that we have done to make sure that it is seamless. And then this pushes right through, you know, in the state of Florida, there are a handful of states that require accreditation. So our HMO is fully accredited with AAAHC, and part of that is we must be able to produce quality improvement studies, CCIPs. We do data mining for identifying trends and opportunities. And if we look at, for example, the diabetic population, what are those trends showing us? Something from the very simple to the very complex. And because we started with the end in mind, our IT strategy was built in that fashion from an operational standpoint and a clinical standpoint, meeting up so that essentially our members could have the access to good care. There's a whole other story. I'm sure you could have another webinar on patient accountability and getting the patient in to have the test. But our system allows to help remind the patient, remind the provider for testing, for HEDIS data, for just good health outcomes. Dr. Hernandez?
Well, and thinking of it from the pure IT strategy, when you start an organization like this and there is a ton of reports that must be generated, you need to be able to get that data together. You need to be able to capture it from day one. And then you need to be able to somehow query that data and put it in an organized fashion, different formats depending on who is receiving that. And in that sense, it is very important to have a system that is interoperable. We also, in our case, for example, we work up our authorizations and then we transfer that into the claim system. So if they don't communicate with each other, obviously that can create significant problems. And I had to look at all those aspects besides the fact that it would work or it wouldn't work. Would it be able to transfer information between one another? Will I be able to then do this in a manner that it will flow? Because just like my department had a certain time to be able to process certain things, the other departments that receive the product of my work also have timeframes of their own and regulations that they must comply of their own, and I have to look at that. In terms of the clinical strategy, one advantage with a system like this is that if there is a case management file, you can look into it, and sometimes they're asking for something for a service in the authorization side, and as we open and we can see on the other side, there is information that will help us in the decision-making process that may have not been directly provided with the request itself. So it is important to have a system that is easy to navigate and is easy to show what you did, because when you get an audit, you need to be able to show what you did. There are systems. We actually had a system that was supposed to be tried on, and it was very difficult to query data. It was not intuitive in its flow, and it was very hard to communicate in other departments with it. Hence the decision that was made to use something that will be, in terms of the front face, much easier to use, and then on the back end, able to perform all the functions that were required to optimally and adequately provide the services to our members at the same time that we comply to all the requirements that the different authorities, whether state or federal, have upon us.
By means of example, could you maybe mention 1 or 2 or 3 systems that you're currently exchanging data with inside your organization?
We're using, for the claim side, there is a system called Health Suite from RAM Technologies. We also have information that we receive from a TRAX system for pharmacy. Mm-hmm. And we obviously have the ACO. We transfer information between those systems, and actually IT in here has created sort of like an intermediate step where we have a data warehouse where everything goes and is a repository and then gets distributed to wherever it needs to go. There is more data than we need on certain sides of one software, and the same applies from the other side of the software, that do not need to be exchanged among each other. And those things are then designed with IT and in cooperation with, in this case, just because we're talking about Encato itself, with a team from Encato, so that we do the appropriate mapping. So they do assist you in getting those things done.
Good. And for the audience on the phone, when Dr. H says Encato, that is the InfoMC care management and the utilization management platform. Let's, from there now, you've mentioned this before, Dr. Hernandez, your concern and your focus on the various stakeholders, of course, the patient, but also many of the others. Let's unpack that a little bit more. What are your main concerns in serving each of your various stakeholders?
Okay, in terms of the members, who are obviously the first and foremost and most important party in this whole relationship, without them, we don't exist. I mean, that's how I have to see it, is to make sure that they get the services that they need and that they get them in a timely fashion and as appropriately as possible. So they need to understand what services are they receiving, or what services are not being given or approved, and why. And it is very important that we have a system that is able to generate communications that are easily understandable to those members for one or the other. And that requires some letters and forms that may need to be pre-formed in the system, and others that will be modified depending on what information you're transmitting to the member. That was possible within this system. Secondly, we also need to do a similar function for our providers and or the requesters of services, which not always is a patient. Sometimes we get, and in fact, more often than not, we get the request from physicians and or providers. And we need to be certain that we also are able to ingest or receive the information they send us in a way that anyone who needs to work with that file can open and make a decision and or continue the flow of that information to the appropriate departments. And that is something that is also able to be done in the system, and to create a communication to the providers itself with the decision about the services that they requested. So in those two is a matter of time, only because, well, some people are desperate to get a service, some people need to have a service timely. And then on the other end is because we need providers to be able to know what their next step in taking care of our members should be. And in that sense, it's important to be able to communicate fast and appropriately. Yeah. When we look to our internal, because we're having stakeholders internally as well, is to make sure that one department can actually determine at what step is a given request or service at, and that we are able to see the information that was received, or if something is lacking, that we can then sort of like recruit other departments to assist, and they can easily get the information to us as well. Third, and as important, because they decide, I mean, they hold the pen by the handle, the authorities, we need to be able to show them what we did, and we need to be able to extract that data and give them the reports that show that what we did was done in the right time frames that they have given us, and with the right documentation steps that they require of us. So there's several different stakeholders in here, and our concerns at the beginning were to make sure that we had a system that was able to capture all of that. The prior system that we were looking into was not able to perform all of the different customer areas in a complete manner, and therefore we decided to change directions.
Yes, so that's great. Susan, I think as an operations person, you will have a very additional perspective on stakeholder relationships and experience.
Yes. I think this is why Dr. Hernandez and I work well together, because he did an excellent job of one portion of this equation, absolutely. And then the other side to this, okay, so we're looking at managing risk in a value-based environment, and when we're managing risk, I mean, the last point is really what I wanted to expound upon. So those other outside entities, if we're not providing correct, accurate, and timely data, there are serious consequences. So for example, we have a contract with CMS, for example, but we are required to submit certain data, RAPs, EDPS. Some of your other MA plans will know exactly what I'm talking about, but actual encounter data, et cetera. But further, we just went through the bid process. Anybody who's an MA plan on the line knows that on June 1st, we closed out our bid. We use data directly out of our InfoMC product in Cato to help with that bid process. Where are we looking to allocate those dollars? It's one to get it out of our claim system. It's another to have it out of our medical management system. The next is with our state. You know, we're a licensed HMO. So in our state, it's called the Office of Insurance Regulation. In other states, it would be your Department of Insurance. If you're filling out, you know, I'm going to date myself for any of the finance people on the line. If you have your orange blanks or your NAIC documents, you've got medical loss ratio. Well, claims need to be able to bump up against the medical management side of it. So when we're talking about a stakeholder experience, how accurate is our data? It must be 100% accurate. So when we process a claim, whether it's pay, pen, deny, we may need a clinical record and those clinical notes out of our medical management system, you know, to determine the status of that claim. And then I'll always say, you know, most states have a Department of Health. Here in the state of Florida, we have the Agency for Healthcare Administration. They work similarly. And because Cato was so, again, flexible for us, we created, in conjunction with your team, I've got to give credit to your team, we had a grievance reporting system, and that feeds to CMS as well as the state. And because of the flexibility in there, we were able to have a system that could produce both reports. So for CMS, there were certain categories and criteria that we must hit. And for the state, they had different categories that we must be able to report on. InfoMC was allowing us to combine those two, keep them separate for reporting purposes, but combine those two as the user, our member services rep, was taking in that grievance reporting. And then, you know, I'll always say one of our key stakeholders in a for-profit organization truly is your governing body. Can we produce the data that is digestible for our governing body so that we can paint a picture and add color to our day-to-day operations such that the board of directors really can make those good strategic decisions? And then one other piece I wanted to add on from the previous discussion when we were talking about, you know, structured data moving in and out, we have the ability, you know, Dr. Hernandez talked about tracks and a few other systems that we have here. And one clear example of that is when we as an HMO have our conversations, and I'm talking about IT conversations, we receive enrollment data. So on this enrollment data, it will tell us a member, for example, is a transplant recipient, let's say. And there's something called an ABI file, ABII. So again, for anybody who knows these CMS acronyms, we're crazy for them. So when we put on an alert or a note in the system for that member, that this member is a transplant recipient, had a transplant covered by Medicare during, you know, an eligible coverage period, there are certain medications, Part B, that are and are not allowed to be filled. And so Dr. Hernandez did a great job of educating our operations department. Behind the scenes, we have to make sure that that one piece of data that is received is transferred from our claim system, our enrollment system, into medical management, over to our PBM, our pharmacy benefit manager. Because if you're a transplant recipient, there are do's and don'ts to the coverage determinations made. So that's just one real life example that in Cato made it so much easier for us to process this. And again, I've been in other organizations where, you know, you go out to a separate file or it's a spreadsheet or, you know, you have to log out and log back in. It was a delight to see that the interoperability of all of our systems, you know, without sounding trite, in Cato really is the core for us. So we can take in the structured data, it can push out the structured data, because at the end of the day, we're managing this risk. It's financial, you know, so that one, we can answer to our governing body, and two, it's clinical, so we have good patient outcomes. That's really a true value-based organization.
Both of you, great perspective on stakeholders, and I think you've covered inside stakeholders and outside stakeholders, upstream and downstream. I really like how you tied it all together. I have one final big question for you, probably the most important question in going through your experience of creating a new Medicare Advantage plan and growing it rapidly. When you think back about the decisions you made together in the past 2 years, what was the most innovative or unexpected decision that you made that turned out to be very critical to your success as an organization? And with that question, that will be the end of our question and answer session, and then hopefully we'll open it up to our audience for some more questions. But I'm very curious to see what was something unexpected that you encountered and that was critical to the success for doctors' healthcare plans.
Susan, you want to take it first?
Sure, because mine is going to sound elementary, but it was unexpected. And so for anybody in the operations side, hopefully you can appreciate this. We do so many complex and very high level, clinical decision making, and boy, we are creative, and we just talked about how great these systems are, how they work together. One of the unexpected and critical to our success solutions, nobody laugh, that we can do batch letters. And so I say this because if you were to speak to me 3 years ago as we were launching this, I would say, well, of course we want to send a letter one at a time, and we want to send a letter batching. Believe it or not, many organizations, many systems cannot batch letters. So when you talk about managing risk, we also have to talk about managing time. So when we have an FTE printing out a letter, and we have a fulfillment department within our organization as well. So they take these letters, stuff the envelopes, put on the postage, get it to the USPS. In order for medical management to have a successful and a really good working team, they should not have to be burdened with the necessity of getting up, printing a letter, signing it, putting it in an envelope, etc. And to batch letter, I know it sounds silly, but it truly was an unexpected decision that we said, oh yes, we want to solution this. And it has saved us. I haven't been able to quantify it yet because I love doing that at the end of a year. But I can already tell you it has saved us tens of thousands of dollars by being able to batch letter.
Yeah.
And then the next is, because we're using the system now for grievance and appeals, we're able to, one of the decisions we made early on as well is that we could appeal one line item within that claim. Again, I know it sounds so simple, but I guess the word of advice to the group listening is really do think about those day-to-day operations and what would make your life easier for your members, your providers, your key stakeholders. And I would have never thought that I would talk about batch letters as an unexpected, wonderful decision.
A great example, Susan, because I think we tend to be focused on high tech, right? On fancy high tech solutions, but I think it's very important for you to also highlight that sometimes there's a low-tech element that you really need, and therefore I think your example is great.
Yeah, and we could not have done it without the high tech within Cato. I think that's the point of it, is something as simple as I want to do a batch letter, we could not have gotten it done without this system. So anyway.
Good. Dr. Hernandez, what is your example of something unexpected that you came across?
Well, I'll tell you what's unexpected. I mean, and I had not been involved with a startup this early in the process. I had been with another startup a little bit further down the line, I would say probably a few months from today, essentially backwards, but not almost 2 years like when I joined in. Having said that, when I was brought in and I looked at the system that they had initially chosen, and they needed my input to make the final decision for utilization management, it was a nightmare for me to try to do it with that system. And when we spoke to Cato and InfoMC, and we made all the decisions that we made, what is the one thing that was unexpected? And it was crucial. I think it was the decision to go in that direction, which we finalized the details, I think it was December. And come January the 1st, we're already working live with this new program, which is, I think, a feat in itself. I mean, to try to get something done within weeks, to be able to begin, essentially to explode, to launch the rocket without having really tested it in depth before, it takes a real team effort. And that's I think, very crucial to our success, and I think to the success of Enqueto as well, in terms of they being able to say that they can do it because they actually shown they did it.
I think that is a great example, and I appreciate your compliment there also. Let's, I would like to briefly summarize the topics we talked about. So lessons learned from our conversation today: single platform for utilization management and case management to support both the clinical and administrative workflows. I think you've both really emphasized the critical need for collaboration between the clinical team and the operational administrative team. So it was great to go into depth there. Data aggregation and interoperability. Thank you for the examples of interoperability that you mentioned and how crucial they are in making your operation run. I loved your focus on teamwork and stakeholders, upstream, downstream, inside, outside, particularly. And I think focusing on that and reminding what our conversation was there is we tend to focus on stakeholders outside the organization. Susan, I really liked how you also included the inside organization stakeholders that need this information to do their jobs. And then finally, the importance of having up-to-date line of sight clinical and financial metrics to enable your decisions. So I think all of those topics came up in today's conversation. And I think there may be some questions from our audience today. And Garrett, to handle that and to manage that, I would like to pass it on to you.
All right, great. Thank you, Dr. Sherpier, and thank you to you also, Ms. Griffin and Dr. Hernandez. This is a very insightful presentation so far. We do have some questions that we'll go through here, and these are in no particular order, and they're not directed to any of you specifically, so you can just take them as needed. The first being, what would you have done differently given what you know today? That's the first question.
Dr. Hernandez, I think you just left off with that. So,
I would have done this a lot earlier in the process. It is not good to look. There's a lot of competing necessities and issues when you're beginning a process that is so gigantic and complex as what a new healthcare company is. So you have to try to get the decisions that are the easiest ones out of the way fast, so that you can then devote yourself to the other issues that require deeper and more detailed attention. And choosing a system, it's a very, very important decision, but it is one that should not be consuming all of your time. If it does, maybe you haven't done the right choice. And that's part of what I think I would have done differently. I would have not been running at the last minute, but then again, I joined a little bit late in the process, so it was actually a combination of issues. Other than that, honestly, everything else we've done, it's been a roller coaster at times, but it's been an enjoyable one, and we've been blessed with success, and I'm glad to be able to at least say that, and to say that we partnered with people who really have become team players. We all are trying to root and accomplish the same thing.
yeah. And if I can add on to that, Dr. Hernandez, the one piece, again, if looking back, I probably would have spent a little more time looking at really diving into the details of the benefits being offered. When you are launching a health plan, and you know, whether you're an HMO or an ACO, if you're looking at the benefit design, all the covered services, can your system handle what you want to administer? Because if it can't, and you need to go outside of your system to handle, and let's just say acupuncture, you know, many organizations now are offering acupuncture. Can your system handle not only the request for authorization, the referral, the claim structure, et cetera, but be forward thinking and really look at every single benefit that you have? Can your system handle that? And that takes a deep dive analysis. And even if you're entertaining 2 or 3 organizations at the same time, or you're already embedded fully, let's just say an electronic health record, where are your limitations? Where do you have to go outside of your core operating system? The more you go outside of your core operating system, the more chance there is for mistake or lack of exchange of data. So do take a look at your entire benefit structure.
Okay, great. Yeah, thank you for that. Next question. It is clear that the platform has worked well for you, but are there functions that you need it to perform that it currently does not?
Can I answer that one? Yes, you need to pay a claim. So I've been saying this to Encato, go learn how to pay a claim and then I'd be happy. But no, for what we engaged InfoMC to perform, they have actually done more than what we expected. There is a new release coming out. I know that we want to enhance, and truly, if this is a call to action, I know I want to enhance the dashboard so that member services can see on a real-time basis if that member has received all of the services to meet the HEDIS cut points, our STARS cut points. So I would say that would be one enhancement I'd want to see. That is an integration. Certainly InfoMC has it, but I want to see more of it. That's all.
Okay, thank you. Okay, moving along to the next question. We're a new Med Advantage plan, and we're looking at medical management platforms. How did you decide what was the best solution for doctors? What set them apart?
So one thing I want to bring up, and Dr. Hernandez, I'll let you speak after me. One thing, if you're a new Medicare Advantage plan and you're setting this out for an RFP, a request for proposal, do take into consideration things such as what Dr. Hernandez said. When our organization made the decision to go with InfoMC, it was unfortunately a bit delayed just based on other circumstances. But one of the items that we made sure of is that our operating system, our medical management system would be available to us and running at a certain percentage of time. And I can't quote the contract, but almost 100% of the time. Nobody tells you 100%. But one item that I will say for medical management, can it fully integrate all of the structured data elements between UMC MDM, and then can that information be pulled out or downloaded, whether it be to an ASCII file, to a CSV file, what have you, to go to your other stakeholders. And then when we look at the downtime of an organization and the guarantees that are in that RFP, Dr. Hernandez talked about it, but I'm not kidding. InfoMC, our organization is open 365 days a year. We are here 7 days a week. So we went live on January 1st of 2019, and at 7:30 a.m., myself and the member services and some medical management team, we were all in here. We didn't go out the night before to celebrate New Year's, or maybe some did, and I don't know about it. But we were all in here, and we had 3 team members from InfoMC alongside of us, making sure that the platform worked. To me, that high touch personal value that is what matters, because there's one thing, and you've got to get your IT team, your IT director, your information systems, information technology director involved from day one to ask all of these questions. But I would say look at your request for proposal, and make sure that there are guarantees in there. And I don't worry about InfoMC showing up for us, because they're always there for us.
Very good. Okay, we got time for a couple quick last questions here, and then we're going to have to go. I did get an email from someone who said that the question module wasn't working for them, and they sent their question to me directly. So if that's the case with you, please feel free to email me directly with your question. But here's the question that was emailed to me. From the perspective of a plasma-based therapy organization, we would love to be able to provide more value to our payer organizations. Do you have suggestions on how to be inclusive of small populations within your plan? For rare disease management, does this data system give you more line of sight to how managing small populations can have an impact?
Dr. Hernandez, you want me to take this one?
Well, let me actually answer a little bit about this. We've handled subpopulations in the modules for care management. Now, do we handle particularly rare conditions? Do we have a specific handling for this particular patients? No, they would just fall into the higher risk, and they will be handled then through the other side of case management. That is not the chronic disease case management. The system is elastic, that you can change things in it, and the team is willing to work with you. You tell them what it is that you need, and if there is a way to accomplish that, they will try it for you. Now, can I promise you they're going to do, a 0.01% scenario and do it flawlessly? I don't know, because we haven't faced that ourselves. But in terms of being able to tailor the system to your needs, that has been a possibility. And again, when you have special needs programs, and that's where you treat chronic conditions and or special populations, it does need to be a flexible system. Whatever they come up with out of the can is usually not quite what you need. It may not be far off, or it could be really far off, but it's not necessarily going to be that way. So you need all the opportunity to go back and forth until it ends up where you wanted it to be. I mean, I think that's the best I can answer that question, given that our experience is not exactly on that particular type of field.
Yeah. So, and outside of our Medicare Advantage plan, it just so happens, if you saw the bio, I was a consultant for a few years, but please know that I'm presuming that the plasma organization is dealing with platelet-rich plasma injections, and I'm going to go forward with the answer based on, for example, a PRP based health facility. So if you take a look at all of the PRP that is being used today, whether it be for orthopedics, aesthetics, pain, etc., when you're doing the PRP and you look at an InfoMC in this medical management system, you would be looking at from time of pulling out the blood, spinning it down, pulling out the Buffy coat, looking at the, if you have the ability to look at the millions, I'm sure you don't, but all of that can be documented in the medical management system. And if you're keeping up with what's going on in Washington, D.C., you know it has to be same day utilization. It's minimally manipulated for PRP. The Encato system has locations, which we as a Medicare Advantage plan didn't use because we do not provide that exact service, but I have seen it in there when we were programming it, that you could have, for example, I always encourage organizations to do a timeout. Why are we here? We're about to pull out this blood, inject it in your knee or your face or what have you. But if you're specific to plasma, know that the medical management platform will work. And then what you would want to look at is the case management program, because again, if we were to take orthopedics, is it 1 injection, 3 injections? Is it your level of sports activity? Is it aging? In the Medicare Advantage space, we are looking at some of those alternative medicines. And we know that some of our primary care physicians right now are using it in order to, help that Medicare Advantage patient have a better lifestyle, let's say, before they go to full injections. But if you're looking at straight plasma, there are components within this system. It will then not only give you a health outcome, you can use it for treatment, for case management, your health outcomes, and then of course I'm always going to encourage that you look at the studies. What was best? Do you do those 3 injections a week apart, 10 days apart? Because we're talking about the Wild West now with PRP, even though it's been around for so many years. It's been around for about 20 years. It's really just getting notoriety though in the past 5 years. So long answer to yes, it can be used in a plasma atmosphere.
Okay, very good. Unfortunately, we are out of time for questions. We do have more that came in, and thank you. And continue, please, if you have one, go ahead and send it. We will get it, and we will answer you via email as we're wrapping up here. Wanted to turn your attention here as we wrap up to the InfoMC virtual exhibit booth on ACOexhibithall.com. And this is where you can go and connect with their team and learn more about them and what they're doing. So encourage you to come over and take a look at the InfoMC booth there. And then I'm putting right now in the chat a link and this link goes to a live demo to register for a live demo that's coming up on June the 23rd of Encato, and it's at 1 p.m. Eastern. So again, that link is listed here on the slide, but I also put it into the chat if you would like to participate in that. We encourage you to do so. So that is the conclusion of today's session. On this last slide, we would like to encourage you, if you have any information that you would like to request, or if you would like to get in touch with Dr. Sherpier or the InfoMC team, please reach out. Their contact information is here on the screen, and we'll leave this up for just a couple minutes here as we wrap up, so that if you want to copy this or take a screenshot, you can. Thank you so much for attending today. This was a very informative session, and hope you found the presentation informative and helpful, and hope that you have a great rest of your day. So thank you for coming. Stay safe.